It's a pleasure to see all of you today again. We have today the presentation will be from Dr. Alon Schwartz. He's going to present a trauma case directly from Jerusalem. Dr. Alon Schwartz was a former fellow at the University of Miami Jackson Memorial Hospital Trauma Center. Excellent surgeon. Very happy to see you presenting today, Alon. Looking forward to a great presentation. Thank you.
Thank you very much, Dr. Martos. Today we're going to present a trauma case with complex blunt abdominal injury. The presenter will be Dr. Yoav Stark. He's one of our general surgery resident. Let's start. Dr. Please go down.
Okay, good morning, everyone. So I was presented. My name is Dr. Stark, and I think we can start. So the information we received pre-hospital was from the EMT report. They reported there was a car accident, a 60 years old female patient, morbidly obese. Where they reported that there was no active bleeding. She was fully alert, tachypneic, tachycardic, pale, sweating with clear lungs, and right lower quadrant hematoma. That was the only injury they reported. When she was presented to the trauma bay, primary survey A, there was no facial trauma. She was mumbling and she was restless with a C-spine collar, and the team was preparing for intubation. B, she was tachypneic with no chest trauma, normal breath sounds bilaterally, and oxygen saturation was 80. Cardiovascular, she was tachycardic, 124. Blood pressure was 156 over 125. The first fast was negative. And with these numbers, she received 2 packed units of blood. D, she was Glasgow coma 9 with pupils round and reactive and moving 4 limbs. On exposure, what we saw, the same what the EMT reported, she had a large seatbelt sign and a right lower quadrant on the abdominal wall. Just so you can understand the location, this was the location of the injury, the only injury that we found. The initial blood gas was pH 7.28 with PCO2 of 53, lactate was 3.5. Just to summarize, the patient appeared to be in shock, tachycardic, tachypneic, with narrow pulse pressure, restless, with a visible blunt abdominal trauma, blood gas as described, and a negative fast. And with this information, the patient was intubated and received the 2 packed blood cells. This was the chest X-ray from the trauma bay. And we continued to a secondary survey. The patient was initially a responder. She was intubated with end-tidal of 32, saturation was 99, and you can see from the numbers that the heart rate, she was still tachycardic, but the blood pressure was much better after the 2 packed cells, and repeated fast was negative. So this is our initial, our first decision point. What should we do next? Should we take the patient to the CT scan or directly to the OR? Should we do peritoneal lavage or repeat abdominal examination, fast, and blood gas?
Thank you, Dr. Stark. Dr. Antrach, Baghdad?
Yeah, so with repeated negative fast, then the options are peritoneal lavage to look for enteric fluid. But in this case, because she did respond, even though she's still tachycardic and her blood gases are improved, I would consider doing a CT scan of the chest, abdomen, and pelvis. And then after that, likely she would need to go to the operating room for probably the bowel injury from the seat belt. But I would still do the scan to rule out. You can rule out a pelvic fracture with a plain X-ray, but because you have a few minutes, if it's readily available, I would do the CT in this case.
Thank you, Dr.
We had just one set of blood gas. We didn't repeat it yet. This is one of the options. Maybe we should repeat it.
Okay, well, yeah, as an initial responder, because she's still tachycardic, I'm concerned about that. I think it's reasonable to repeat it. If there's concern about her stability, then I would consider, where you have the chest X-ray, I would do a pelvic X-ray with the rule out femur fractures as well with the same film, and possibly consider a peritoneal lavage. If you're concerned that she's not stable enough, and I'm not there, I have to see how everything looked, but those are the two options.
Thank you, Dr. Antrach. Dr. Kasim, Portland. Dr. Kasim, can you hear us? Well, okay, Dr. Hochman, Boston.
Okay, I'm sorry, I probably misread, but she was tachycardic by hypertensive when she arrived, the first set of vital signs. If you don't mind going a few slides back, because I don't understand why she got the blood. There, she
Thank
was,
you. That is correct.
the blood pressure was 156 over 125. So you have a patient who has an altered mental status. Even though she might not have facial trauma, she might have a head injury. That would be one of the concerns. Secondly, she had, after that, when you do the ABG and you do the chest X-ray, she has CO2 retention that maybe this is acute. Maybe that's the reason that she has the altered mental status. Maybe she took some drugs. I really do not know, but those things that I would be worried. But this heart rate and blood pressure, I will assume if the CO2 retention is acute, is related to the CO2 retention. It's kind of surprising. She has a mixed acidosis. She has lactic acidosis and she has a respiratory acidosis with the combination of high CO2 and high lactate. So it's a little bit confusing picture at this time. She got blood and she is kind of like stable or metastable. I agree with Dr. Untrach. My main concern with this mark in the abdomen is from the seat belt that she has a bowel injury. She had a negative FAST, but as a matter of fact, recently I had to review a bunch of papers about FAST, and I found one very interesting one by some radiologists, which they kind of demonstrated that unless you have a lot of fluid, the FAST is going to be negative. We as trauma surgeons tend to put a lot of emphasis on the FAST, but you have to have a significant amount of fluid for the FAST to be positive, which in this case, it could be from the bowel injury, it could be for many reasons, but it's nothing that even with a positive FAST at this time, I would not take the patient to the OR. She's hemodynamically stable. I would do a head CT first. Depending on that, I will continue with more scans. But if the head CT has a significant injury, I will go to the OR and do maybe a diagnostic laparoscopy, sorry, a peritoneal lavage or something in the OR. Otherwise, I continue with the scans and see what I have. Maybe she has fluid because she has a liver injury and not a bladder injury, a bowel injury. So at this time, for me, I wouldn't do a DPL on the trauma bay because she's morbidly obese. It's really too complicated. I think that if it's any questions, it fast replace it completely. So I will go for CT scan if I can, including the head and including the chest. And if not, if there is any concern of bleeding inside the abdomen, I will just take her directly to the operating room. But I don't have that concern at this time. Thank you.
Thank you, Dr. Ahmed. Dr. Kasim, can you hear us?
Yes, I can hear you. Good morning.
Perfect. Thank you,
Let's
Doctor.
go back to the beginning. This is a morbidly obese patient, as the presenter has told us. So the whole different dynamic plays in a patient who is morbidly obese, and they don't ventilate very well, they don't breathe very well, and she comes in with an obvious seat belt injury. So you need to do a thorough examination of the abdomen, and also she needs to be rolled over to look at the back to make sure she does not have any spine injury. Sometimes that when you have a seatbelt signs as depicted on the picture here, they may be concomitant spine injuries as well. So be aware of that. I think several months ago I presented a case like this. The patient had significant injury to the lumbar spine. For BSMA, so we have a patient who actually comes in with hypertension, and I don't know why the presenters administered blood initially. There must have been some very good reason for that. In a hypertensive patient who is tachycardic, you don't need to give blood initially, but it may be necessary later on if circumstances warrants that. So obviously, we are looking at a patient who has a seatbelt sign, a telltale sign of injury, and she is sustained. And underneath that seatbelt sign of viscous involved, and also blood vessels are involved as well. So any of these integuments could be torn. She could have torn her mesentery. She could have torn her small bowel, or even the cecum in that area. And underneath that is iliac vessels and vena cava as well. So two of my colleagues have talked about DPL. I don't know when I last saw a DPL. I think it was in the ancient time. I don't think DPL is employed in my institution or any other institution that I have worked in. And I think it is one of those relics of ancient medicine, surgical investigations. I think if you want to do anything at all, this patient should go to, if she is stable, which she appears to be now that you have intubated her and corrected her respiratory acidosis, she needs to go to the CT scanner to look at the abdomen as well as the spine. The fast is only good when it is positive. It doesn't mean anything at all when it is negative. That's what I've been taught. So when I see a negative fast, I ignore it. I go back and re-examine again and again to see if that is what it is. But a positive fast is a very good information for me. A negative fast is a useless information for me at this moment. So my take at this moment is this patient needs to go to the CT scanner so that I can plan what I'm going to do. And I must not forget there might be an associated spine injury as well. And I want to be very careful in moving the patient to and fro to the CT scanner. Thank you.
Thank you, Dr. Kassim.
Valeria, I want just to answer for Dr. Kassim's question why we decided to give blood. The thing that made us worried were, first of all, the Glasgow coma scale, which was 9. So first of all, the conscience level, and then also the narrow pulse pressure. She had like 150 over 125, which is very narrow pulse pressure. And with the tachycardia and narrow pulse pressure and decreased conscience, we were worried that she's in hemorrhagic shock, although her systolic blood pressure is 150. This kind of patient tricks us, you know, the numbers sometimes give us a false feeling, and we were worried. This is why we gave the 2 red blood cells.
Thank you, Dr. Schwartz. Dr. Antros, you have a comment about this?
If everyone has commented, I can wait till the end of the comments. Has everyone
yeah,
commented
Dr.
this
Supa,
round?
we have Dr. Supa. Dr. Supa, would you like to make a
Yes,
comment?
after Dr. Supa. After Dr. Supa, yes.
I agree with getting a pelvic film in this patient, and if she's stable enough, send her to the CT scan to check her brain, see spine, chest, and abdomen. Thank you.
Thank you, Dr. Supa. Dr. Antrach, go ahead.
Yes, about the blood pressure, with obese patients, it depends on the match between the cuff and the arm, she's really obese, and you can get a falsely high blood pressure. So it depends on whether you think that blood pressure was accurate. And I sympathize with the pulse. I would put more stock in the pulse because you get tachycardia before you get hypotension anyway. And if she had baseline severe hypotension with obesity, then that would be her blood pressure when her pulse first goes up in stage 1 shock. The other thing about the peritoneal lavage, I haven't done it in years. The last time I did it was, I think, 33 years ago, actually, a peritoneal lavage. And it was for actually what turned out to be a bucket handle injury in a patient that was otherwise stable. And that was before FAST. And the current indication is still described in the 10th edition of ATLS. The indication is an unstable patient with a negative FAST, and you're not sure that the problem is in the abdomen. That would be the indication. So if she were stable enough to go for the CT, I would prefer that. But or you can just, if everything else, if the pelvic and femur X-rays are negative and chest is negative, and she's unstable, you can just sort of make an educated guess and go straight to the OR. But there's still a rare indication for the DPL, and some of us can still do it. I don't know about Dr. Stark, probably not he, but Dr. Schwartz maybe. I don't know, but the rest of us, yes.
I think I did it once in writing.
If I can make a quick comment about DPL, Dr. Kasim is totally correct. This is an ancient saying. That's the reason that we, the old guard, have done this. I've done so many as a chief resident. I hate them doing them because it's time consuming, and it's my residents are all dreaming about doing one because they hardly do one during the whole residency. We don't do them anymore. The only indication that we have kind of in our protocols, and I don't remember when was the last time we did one, probably like 10 years ago, is patients with head injury that we can only do the head CT, and we take them to the OR and we are suspecting something in the abdomen. And we will not do, because they have a head injury, we will not do laparoscopy, because laparoscopy replaces that weird indication that you don't have the time to do anything. So having said that, we are practicing in trauma centers in the United States. The audience here is very wide. And one of the beauties of this conference is that many times we find out that I've been in this conference many times when I say, well, I will do a CAT scan, I will do this, and another surgeon in another place of the world says, well, we don't have CAT scan, or we have CAT scan from 9 a.m. to 5 p.m. Monday to Friday, and it's in a weekend. And they managed to solve the same problem that we solve here. We solve the technology. So that's very humbling, and it's very good for the junior faculty in places like here in the States to see that there are more than one way to skin a cat or do things. So I think it's very valid to mention this here for all those reasons. Thank you.
Thank you, Dr. Ahmed. Dr. Stark, we go back to you.
Okay, so I will just summarize. Basically, we agree with all the opinions that were said, but we were still worried about this patient, her conscience level, her tachycardia, and especially the thing that you can get the feeling of how her belly looked. She had a huge hematoma on the side of the seat belt, probably the abdominal wall, but it resembled us like the amount of energy that her abdomen sustained. And because of that, we chose the fourth option here to repeat the blood gas and then take the decision if she's going to the CT scan or to the OR. So, Dr. Stark.
Yes, so the repeated blood gas was, as you can see on the screen right now, the pH became was worsening. The pH became 7.15, PCO2 66, base excess -7 almost, lactate was 5.5. And with this information and these numbers, we decided to take the patient straight to the OR. She was taken to laparotomy, and the finding was as described. So upon entry to the abdomen, we saw there was a large hematoma with severe damage to the right abdominal wall, dissection of the muscles of the abdominal wall. Inside the abdominal cavity, there were segments of small intestine floating in the abdominal cavity. Just to try and organize it. So from the trites ligament, 50 centimeters were normal looking. Then we had segments with 30 centimeters of a bucket handle injury, another 40 centimeters that appeared normal with a perforation that was primarily repaired. There was additional ischemic looking small intestine, and the end of the small intestine next to the ileocecal valve was normal looking. Altogether, 180 centimeters of small intestine appeared to be damaged beyond repair. Additional finding in the laparotomy was that the right colon, the cecum in the right colon, was detached from the peritoneum. There was a hematoma on the mesocolon. The rest of the colon looked normal. There was a retroperitoneal hematoma in zone 1, anterior to the IVC, with a ruptured right gonadal vein and active bleeding that was controlled during the surgery. And the liver, spleen, stomach, duodenum, kidneys, ureters, and the pelvic organs were all normal. And this is leading us to the next decision point of what to do. Oh, sorry, let's see some pictures. So this is how it looked. There is a font here. Here you can see on the top. You can see the bucket handle injury. And these are the numbers that I described before. Okay, and this is the floating parts of the small intestine that we found in the abdominal cavity. So this is the next decision point of what to do next. One was to try and do an anastomosis between the parts of the small intestine to establish continuity, to do a stoma, or to do a damage control surgery.
So I remind you that we still don't have a scan. Yeah, we don't have more information about the other parts of the body, and we are in the operating room. The patient is pretty much stable after the blood units that she got. There was not a lot of bleeding in the abdomen, just the vein that was ligated, the gonadal vein that was ligated, some bleeding from the mesentery, but the patient is pretty much stable, but we still don't have any CT exam. So what should we do now?
Thank you, doctors. Dr. Supa, Bangkok.
If she's stable enough after what you've done, I think you can try to join the bowel together. If the bowel, if two ends of the bowel look good enough and the patient is stable enough, you can join the bowel together and do the temporary abdominal closure and plan for second loop operation. Or you can just leave the bowel in discontinuity and do the second loop operation to assess the viability and do the anastomosis later. But I don't agree with doing any stoma at this point of time. Thank you.
Thank you, Dr. Supa. Dr. Kasim, Portland. Dr. Kasim, can you hear us?
I think at this point, I would initiate damage control surgery, and I would staple off the ends of the bowel. I am worried about the cecum as well, and being a very aggressive surgeon, I think my inclination from the initial injury, i.e. the right lower quadrant, And the amount of damage it has caused and the way the cecum looks, I think I would staple that as well. I would resect that. I would not leave that behind. As Dr. Supa says, there is no reason to consider anastomosis in a patient like this. And you want to get the patient injured part removed, stapled, and get the patient back to the intensive care for rewarming and resuscitation. While you're there, I think one of the things that I probably will have a quick look at to make sure there is no other injury to the blood vessels, especially the iliac, and you already have looked at the inferior vena cava and you have determined there is no injury to the inferior vena cava. And of course, the midline structure is the abdominal aorta. Sometimes they get bruised as well. They get blunt trauma, and he could have injury to that vessel as well. But luckily that she does not have any other major injuries, but it is very difficult to ascertain the kind of damage she could have in the pelvis unless you have done pelvic x-rays or CT scan or something like that. So I think you do the best you can at this moment to get the dead and dying bowel structures removed and do a washout and get the patient back to the ICU and then plan on revisiting the abdomen in the next 48 hours. That's what I would do. Thank you.
Thank you, Dr. Kasim. Dr. Antrach, Baghdad.
Yeah, so I didn't get to see in the photos the cecum, but it looks like you left it behind, so it must have looked okay to you. And then a lot of segments of small bowel, so cecum. Where's this? Well, you didn't resect the cecum, so anyway, so that's you know, it looked. I guess it looked okay to you not to resect right then. But you have several segments of small bowel. I don't know how many anastomoses you'd have to make, and it sounds like you're concerned about other injuries in the patient as well. So if I had with that concern, then I would be possibly inclined to play it safe because you're ahead. You're winning at this point. Maybe leave the abdomen open which would have the secondary benefit of reducing the possibility of abdominal compartment syndrome with such an obese abdomen pushing against the lungs and making it hard to ventilate. So I would consider that, leaving things the way they are, and go ahead and do the scans. About the head injury, she was moving all fours, was awake and mumbling, and there apparently no signs of focal intracranial injury, but she may have had, axonal injury or non-focal. Nothing that would need a craniotomy, though. But I think it's still reasonable if you're concerned to keep the abdomen open, damage control, go ahead and do the scans, and then plan to look the next day, and then you could re-inspect the cecum.
Thank you, Dr. Antrach. Dr. Ochman, Boston, your comments?
I always tell families and patients that the way that we proceed in trauma is first we go looking for things that are life-threatening. After that, we look for things that can cause serious disability, and finally we go for the rest. In this patient, you are still in the phase where you still need to be looking for injuries that are life-threatening. You do not know what's going on in the head. That chest X-ray was kind of worrisome. It looked like she has a large pulmonary contusion on the right, and you don't have a head CT. You still have a lot of questions that are unsolved. So I will make sure that the situation is controlled in the abdomen and in the sense that there is no more bleeding. One mentioned, I had one patient that essentially bled to death from a ruptured epigastric artery, and you say that this patient has a large hematoma in the abdominal wall, so I will look for that maybe. But after that, this is a damage control surgery. I would not do a stoma. I would do I would not do an anastomosis. I will come back later on. I would try to save as much bowel as I can because I know I have to come back. So I can look then and see if they need more resection. But you resected a lot, so being conservative and not being too aggressive in the initial resection, I think is the way to go. So if we do damage control, take the patient to the scanner. I will scan all the other things, looking for serious disability. I suspect that you have to suspect patients like this with seatbelt injury. When they have thoracic injury, they have 15% chance of having a spinal injury, even though she was moving everything. So that will be my approach. Damage control, CT scan. That's it. Thank you.
Thank you, Dr. Rahman. Dr. Schwartz and Stark, we go back to you.
So this was also our decision, especially to leave the bowel, to leave the cecum and to see how it will look like in 2 days, and especially get more information about the other injuries, which were surprising. You will see in a second in the CT scan. And actually, Dr. Kassim was pointing to this kind of injury, which is pretty much rare. And so Dr. Stark will proceed with the CT scan.
So yes, the patient was taken from the OR with an open abdomen to the CT scan, and what we found, in addition to the damage that we found in the abdomen, was a fracture of the D12 vertebra and an infrarenal aortic wall irregularity. I will show some pictures. So here we can see the damage to the aorta. Here we can see, sagittal view. On purpose, we're not calling. We're still not calling this injury by name because this was part of the this discussion. Yeah. Okay. Yes, and here we can see the fracture and the damage to the aorta in one picture. And this is leading us to the next decision point. So the first and very important was to define the injury, because it was affecting the next step. So is it just an intimal tear, an aortic dissection, a pseudoaneurysm, or a full rupture? We had a discussion with the radiologist that it was very hard to define from the CT scan. And then after deciding what is the next step, so should we treat with aspirin and low molecular weight heparin only, or do an endovascular repair or an open vascular repair?
So this is the next question, and if you can consider, of course, the GI contamination of the patient with a lot of GI content that was spilled into the open abdomen, which is each one of the options. So I'll show again the imaging. You see this in coronal view, and maybe the sagittal view is the most impressive. This is exactly where the fracture, the vertebral fracture in T12 was, and this is like a chance fracture, a fracture between the seat belt, the intestine that was in the middle, the vertebra, and the aorta, the ascending abdominal aorta infrarenal, which is pretty much rare. So this is the question.
Thank you. Dr. Rahman, Boston?
What type of injury this? I don't know. The radiology couldn't tell you. It looks more than an intimal tear. Usually what we call an aortic dissection in the chest is really aortic tear. It's the difference between an aortic dissection and aortic tear. Having said that, this looks very much like a dissection. So really, whatever it is, I think is more than an intimal tear that you can treat with aspirin and follow up ultrasound or CT. I would have to involve the vascular surgeons here for something like this. If this was bleeding on the table, that would be my area. But if it's a case like this that's not bleeding on the table and you have some time, I will definitely the vascular surgeons, and most likely than not, and I'm guessing here, I'm not a vascular surgeon, but based on everything that they do, they will do an internal stent for this rather than doing an open surgery. But that's all I can say. This is a very interesting injury. Let's say that. Okay, thank you.
Thank you, Dr. Ahmed. Dr. Kasim, Portland. Dr. Kasim. Okay, we go back to him. Dr. Supa, Bangkok. Dr. Supa, can you hear me?
In this case, I think we have to rule out the possibility of aortic rupture. The CT scan could be internal injury or the complete transection of the aorta at this level. So I would talk to the radiologist and ask them to review this carefully. And I'll call the vascular team because I think aortogram would be the gold standard for diagnosing this condition. And for treatment, if she has like aortic rupture, we should try endovascular repair for her because for the location, it's infrarenal aorta. There's no important branch that cannot be occluded. So I think we can try to do the endovascular stenting to treat this condition. And it's good for a contamination too because she has bowel injury. To do the open repair and put the aortic graft intra-abdominally would be dangerous for her because she may have graft infection later. So I'll call the vascular team in, check the aortogram, and if she had rupture of the aorta, aortic stenting. Thank you.
Thank you, Dr. Supa. Dr. Kasim, can you hear us?
As I mentioned in my previous discussion, that I have seen this. It is a crush injury between the seat belt, abdominal aorta, and the spine. And the abdominal aorta gets crushed. And initially, it's a minimum tear there inside, and then the thrombus forms, and you get a picture like this. And I think in the case that I have dealt with, the endovascular surgeon put a tube stent in there and called it a day. And I think that's what I would do in a case like this, because you have a tremendous contamination of the abdominal cavity with enteric content. And any type of open repair would be fraught with infection to the graft, and it will not bode very well for the patient. The reason I mentioned all this initially, you have to look at all the organs, including the midline structure of the abdominal aorta, was the amount of energy this lady has sustained is enormous. It is not a small little seatbelt injury that most of us have seen in our clinical practice. But this one is a serious injury, and therefore she has a serious problem to her spine plus vital structures such as the abdominal aorta. And it needs to be dealt with immediately. And I think I would call on my interventional radiologist to see if they can, or vascular surgeon, to do a tube graft to this area. And then follow it up with some type of blood thinning protocol that you have in your hospital. Thank you.
Thank you, Dr. Kasim. Dr. Antrach, like that?
Yeah, so I'd be interested in the quality of the pulses in the groin compared to the arms. How is the blood flow to the legs? But and I agree with everyone else that although I don't know, usually if there's like a ruptured thoracic aorta after trauma, you usually see a hematoma outside the outline, and this seems to be confined totally within the lumen and the vessel wall, but it's academic. I think, and I agree with everyone that this kind of patient, you wouldn't want to do an old-fashioned graft. It's just, obesity, the spillage, everything else. It's just, the complication rate is likely going to be very high. But I agree that if she needs anything done, it preferably intraluminal endovascularly.
Thank you. Go ahead, Dr. Rahman.
Yeah, one thing to take into consideration, if you do this, it should be done before going back to the OR, because if it's an endovascular stent, it's going to cover the IMA, which is clearly visible at the level of the injury, just distal to the distal part of the injury. So that will be occluded for sure. So you can evaluate the left colon at the time that you go to the OR.
Thank you, Dr. Rahman. Dr. Stark, we have a question in the chat that says, so far, how has been the hemostatic resuscitation?
He was like even after the first operation, she was stable. During the first operation, after getting like two units of blood or 3 units of blood, she was stable hemodynamically. And respiratory, she did had this right lung contusion that you can see in the chest X-ray, but we could oxygenate her. There was no respiratory problem under the ventilation. So hemodynamically and respiratory, she was fine. Actually, this last point that was said about doing the graft, the EVAR before the operation is very important. We didn't do it, but it's very important. It's true, but we didn't do it like this. Actually, we also consulted the vascular surgery team, and they weren't so impressed from the injury. They recommended us just to put her on us and Lovamax and not do any graft. And we actually had to fight about it. So Dr. Stark can continue the next.
Yeah, so as Dr. Schwartz described, we did consult the vascular team, and initially what was chosen is a conservative treatment, and then next on POD 2, post-injury day 2, we went for a second look, a re-establishment of a continuity of the GI tract. Altogether, there was 110 centimeters of small intestine. No ostomy was performed. And after the second look, what was done was an EVAR procedure. We can see the pictures. Here we can see the injury, and next we can see the stent in place. So that what was done. Next, just in a short presentation on PID 8, she was extubated. Where PID 10 went down from the ICU to the surgical ward. She had a very complex
complication.
Yeah, she had a very complex stay in the ward. She had after we went back for enteral feeding, she had a massive aspiration, full arrest, CPR, ECMO, back to the ICU. She recovered from that as well. Later, she developed an enterocutaneous fistula to the wound site that was treated conservatively and closed spontaneously. And then on today,
actually today, she was discharged home.
Walking on her 2 feet, eating, and the fistula is closed.
Thank you very much, Dr. Schwartz and Stark. Congratulations. Are you ready for the final comments?
Yeah, we're ready.
Okay.
But we got already, we had to do the EVAR before the real laparotomy. That's a very good point that we missed.
Thank you. So Dr. Kasim, your final comments, please.
I must say, Dr. Schwartz, I'm so glad this patient ended up in your hands. This is fantastic. the way you approach this, such a complex problem. I take my hat off to you. You must have had a fabulous time in Miami. The way you approach this, just marvelous. I really like the way you did this. The only difference would be I would have done the EBR before I did the second operation. But be that may, this is a very good save and just superb. Thank you, sir. Thank you.
Thank you, Dr. Kasim. Dr. Antrach, Baghdad?
Yes, so very, very impressive case. Great save. I think the her expected mortality, given the injury severity score and the comorbidities, was relatively high. So I'd be interested in knowing why initially the vascular surgeon demurred on the EVAR and then changed the mind, whether it's the same surgeon, number one. Number two, about the ECMO, it looks like you started after 10 days, and I assume it was related to hypoxia because of the aspiration. So how did that go? How long did she need it? And do you think that that made a difference in her survival? And thirdly, I would caution her that on the ride home, despite everything, she should wear her seatbelt.
So for the first question, it was the same vascular surgeon. You know, Israel is some kind of socialism. It's not completely capitalist. So we have a vascular service, and then they have like their discussion, and they make the decision together. It's not that you can go to another vascular surgeon and he will perform it. So they did it in their service. It was the whole weekend. It happened on Friday, and the whole weekend, Friday and Saturday, I was with him on the phone, just trying to convince him that this is not an intimal tear. This is at least a dissection or pseudoaneurysm. It wasn't a rupture because we were in the abdomen, and the adventitia was complete. There was no like hematoma around the aorta and the bifurcation. We were there, but the imaging, and also we went back and forth with the radiologist that try to define how to call this damage, and according to the name of it, to try to see what is the right way of treating it. Eventually, so the claim not doing it was the GI contaminant. They said the patient had like abdomen full of feces. Now you're gonna implant a stent, covered stent that can, and with the bacteremia will get infected also, and then you're with arthritis, like septic arthritis, you're in big trouble. So this is one of their claims, and also because she had like good pulses with this injury, there was no like a lack of pulses. So they said, okay, we can just give her aspirin and heparin and do a repeat scan. Actually, this is what convinced them. We did a repeat scan, and the injury looked the same, and this is what convinced them to do it. You know, if I would do it, it's my decision. But when you have to get other people to do it, so you have to be involved with their opinion also. And this is what happened, but eventually we managed to convince them, and they did it. So this is for the first question. The second question about the ECMO. So the ECMO was for about a week, I think maybe 6 days. Of course, after the aspiration, we started the tube feeding, and she was completely awake. She was extubated. She was in the ward. She wasn't in the ICU already. And at night, everything happens at night. This is what she did, like a massive aspiration, vomiting, aspiration, and then she needed like repeat intubation. She was in CPR also, and we put her on nitric oxide, which also didn't help. And her PO2 level was about very, very low, like about 30. So we had no chance, no other chance either just to lose her or to put her on ECMO. And after about 6 days on ECMO, we could take it out, the cannulas. And of course, seat belts is recommended in any case. Of course, we know like with this kind of energy, without a seat belt, she wasn't with us anymore, so no question.
Thank you, Dr. Schwartz. Okay, Dr. Supa.
Okay. Thank you, Dr. Schwartz, for presenting this case. You not only treated her injuries, but you have cured her obesity too. She looks thin. That's right. Very good job. Thank you very much.
Thank you, Dr. Supa. Dr. Ochman, Boston.
I would say that based on the pictures, for America, she was thin already. But I have really nothing to add to what Dr. Kasim said. This was an extraordinary save. This patient had more chance of dying than being alive, and is alive because of everything you did. Even after she aspirated and needed CPR, ECMO, and she walked out of there, this is really very, very impressive. Congratulations to all of you.
So there is a question here from in the chat, why we chose to do the anastomosis and not bring an anastomy out. So we had just 110 small bowel length with one anastomosis or two anastomosis, I think, during the with the segments. And to bring this as anastomy, I think this is a death sentence because very high output. So we took the chance. You know, she has her colon. And we did the anastomosis. We had a fistula, but the fistula closed eventually by itself, as fistula does. So it was a chance. We took it as the chance, but to leave her with anastomy of 110 small bowel, I think was worst decision.
Okay, thank you, everyone. Please take a moment to look at the screen. I'm sharing the code for the CME.
Can I make one more comment, Valeria?
Of course,
it is amazing. It's amazing how our colleagues in this other discipline, how they react when you ask for help. Especially when you ask for help during weekends, when you ask for help during nighttime, they always kind of hedge one way or the other. That has been my experience. And I don't know whether other people have experienced that or not. Clearly, this thing needs to be done. I don't know why the vascular surgeon hummed and hawed about it. I'm so glad that you persisted him to do this. And without him doing this, eventually this lady would have thrombosed the abdominal aorta. Very good save, doctor. Very good.
Okay. Thank you very much. Thank you, everyone, for joining. And next week we have a case from Ryder, so we hope to see you next week.